Good evening. Can you hear now? Good, thank you. Good evening and welcome to the second PharmTalk in our fall series. My name is Rick Schnellman and I am the Dean of the College of Pharmacy. I will begin tonight's event by respectively acknowledging the University of Arizona is on the land and in territories of the indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign native nations and indigenous communities through education, offerings, partnerships, and community service. The PharmTalk lecture series is an opportunity to learn about the breadth and depth of pharmacy and how the college contributes to addressing healthcare challenges. Whether you are a healthcare professional or simply curious about the field, I hope you will find tonight's talks informative and engaging. Thank you to our speakers for this lecture possible, and all of you tonight for joining us. Now, let's move on to the first topic. From virtuous synchronous and asynchronous clinical visits using remote patient data to advance care and leverage technology as a tool to improve medication adherence, pharmacists are innovating and delivering care in new ways. In this talk titled PharmTech, Innovations Enhancing Patient-Centered Care, Assistant Clinical Professor Beth Zerr will share how pharmacists are incorporating technology into the practice to provide patient-centered care. Please join me in welcoming Dr. Zerr.
All right, thank you for having me. My number one goal while I give a talk about technology is to not look like I don't know how to run the technology. So we'll see how that works. So far, so good. Oh, nope, this is Ashley's talk. Okay, I can fix it. This is my talk. Okay, now we're back. PharmTech. As Dean Schnellman said, my name is Beth Zerr. I am originally from eastern Montana, so if anybody's from there, you might recognize this picture. This is a picture of Makoshika State Park. I purposely picked a photo with no people because there were not a lot of people where I grew up. I was kind of always searching for a more metro area where I could have more interaction with people. Didn't know it was going to be in healthcare at that time, but that's where I ended up going, kind of more metro. Tonight, my talk's going to focus on how we can use technology to help improve the care of patients. So I started off in Montana, moved on to Minnesota, purposely picked a winnery picture so you can all feel happy about your choices to be in Arizona right now. Went to the University of Minnesota where I got my PharmD degree. After that, I completed a one-year post-grad residency that focused on, it was ambulatory care focused residency. After that, I took a job as an ambulatory care provider. So if you don't know what that is, it basically is working in the clinic directly with patients, getting a chance to manage mostly chronic disease states. So one-on-one management with the patient under an agreement with their primary care provider. Can stop, start medications, can order appropriate lab work, kind of in charge of some of their chronic disease states. I focused on diabetes, hypertension, lipids, asthma, COPD, and smoking cessation. So kind of like the most chronic disease states that you would encounter. Also, while I was in Minnesota, spent time doing polypharmacy medication reviews. So that's just looking at patients' full medication list and seeing if there's any opportunities for improving. So that could include getting rid of medications or deprescribing, which you're going to hear about more from Dr. Campbell. Also making sure that they're on the right medications for them. And then seeing if there's any opportunities to make the meds that they're on better. So getting a chance to look at the whole patient. And then one of the other things that I did while in Minnesota was completing home visits with a team that was designed to reduce readmission risk. So I worked on a team with an RN, a social worker, and then a care guide, which was a lay healthcare person, and we would visit patients in their home after they've been in the hospital, trying to reduce their risk of getting back into that hospital, especially during that first 30-day period where they're most at risk. Moved on to Arizona. My family and I have been here about 7 years, and when I moved here, I took a job here at the University of Arizona as clinical faculty, which meant I also spent some of my time working as an ambulatory care pharmacist again. During my work there, and this was pre-pandemic, started a telehealth clinic, so getting to work with patients completely remotely. And then when the pandemic hit, we were ready to roll because we already knew how to work with patients that way. But everybody had to get more creative about, how do we take care of patients? How do we get the information we need? How can we make a good impact in their life without having that traditional face-to-face visit with patients? So that's what I'm going to talk about today. So what is telehealth? And the most obvious answer for what telehealth is it's a phone visit with your provider. So it really just means anything that's not face-to-face, that traditional clinic visit with the provider. But there really is so much more than that, and that's what we're going to focus on today. Get my presentation back. There we go. So what I'm going to talk about today are some things that the American Academy of Telehealth Medicine has determined as like the pillars of telehealth: asynchronous interactions, remote patient interaction, and virtual visits. And then I added in an extra one because I'm a pharmacist and I am passionate about anything that can help patients take their medications better, the way that we prescribe them, the way that we know they work the best. So we're going to talk some about adherence tools as well and how technology plays a role in those. So first off, a disclaimer. All the rest of my slides are featuring a ton of photos of different products that I am not affiliated with. The university is not affiliated with. I'm not saying one is better than another, just simply presenting products that I've had experience with. I could probably answer questions about some other company products too if you have a question about that, but just throwing that disclaimer out there. Okay, so the first two kinds of telehealth that we'll talk about are probably the ones that might be most familiar to you. First of all, there's virtual visits, and this is really any sort of live interaction with the patient that's not happening face-to-face in a clinic. Most common one would be a video visit, so like a FaceTime with your provider. Many of you may have had these specifically during COVID. A lot of health systems switched over to these kind of visits. Many large health systems had their own platform for a video visit. So they have their own software, their own way of doing it that is HIPAA compliant, basically just meaning that they keep track of your information in a safe way. But there are also products out there that are pharmacist specific that go direct to the consumer, so not associated with a health clinic or a health system. And this one on the slide on the bottom there, that RX Live, is an example of that. So this is a telehealth video visit product where patients can sign up directly saying, hey, I want to talk about my medications with the pharmacist. I want to have a consult. So they sign up and they're connected with the pharmacist in their state. So that's a newer area. This is definitely growing. There are a couple of different companies that do this right now. You may have also heard about this with other healthcare providers too. There's mental health providers that have the same kind of video visit network as well. Also under virtual visits, again, any sort of live interaction. You can have a chat interaction, basically like texting with your provider. I've had some experience with this as part of my post-readmission work. I'm trying to keep those patients out of the hospital. We would, in addition to visiting them in their home, we would also have some chat set up with them. So I would text them about once a week just to do a quick check-in. If things were going well, then we wouldn't have to have another visit, but if they weren't, then that would alert us for another visit. So an example of virtual visits. Moving on to the asynchronous interactions, exactly what they sound like. Basically, it's a store and forward interaction with a provider. So you're not live, you're not having a live interaction or conversation with that provider. The easiest way to think about this is emailing your physician and having them email you back, or getting an email through a secure patient portal system where, say, you might get lab results with a little bit of explanation. There are ways that pharmacists can provide care in this function as well, As part of my work in my telehealth clinic, we had some patients who really, their schedule just did not allow for even an in-clinic visit or a live video visit. So we had patients we managed completely through the portal system. So had it set up kind of like a template, a form template that we would email out to the patient, answer these questions about your medicines, about your disease state, and let's get this conversation started. So we can manage patients completely through that email portal system. Okay, this part is more exciting in my opinion, the remote patient interactions, and it's really where technology has been exploding recently. A good way to think about this is any sort of thing that a patient can do on their own to monitor their health and then send that information to the provider. Most often, these products are Bluetooth enabled, so they have some sort of ability to send information to an app, which then can be shared with whomever the patient would like, whoever they give permission to. So that could be another caregiver, it could be a family member, it could be their physician, or it could be me, the pharmacist. So what's up here right now is an example of a CGM, or a continuous glucose monitor, something that's used frequently for diabetes management. Relatively new within the last, say, 10-ish years. They are becoming much more widely used, one, because we know they're helpful, they help patients do a better job of taking care of themselves, and two, because insurances are paying for them a lot more frequently. So what this is, so in that first picture that has the circle and then the blue device, the circle is the sensor, and that's what the patient wears on their body. So if you think about traditionally how we manage diabetes, we need to know where your blood sugars are at, because it's all about keeping blood sugars in the correct range. And before we had something like a CGM or a continuous glucose monitor, patients would have to poke their finger, then we figure out what is their blood sugar right now. And that's all that gives us. It just tells us right now what's their blood sugar. As opposed to something like a continuous glucose monitor, you wear it on your body, usually on your upper arm. It is checking your blood glucose all the time. So think about how much more information we're getting, one as a patient, two as a provider, just from having this device on your arm or on your person. So an example you can use, so you wear that sensor, and then the blue product there is the receiver. So the information gets sent to that receiver either continuously or say like every 2-3 hours, depends on the product. Or the patient can bypass that receiver completely and have it connect via app on a smartphone. And that's what most of my patients do, is use their phone. Then the larger graph picture with all that information is what the patient can see. So the patient has all this information at their fingertips all the time. It shows them kind of a chart, where their sugars have been going. They can put notes in there about like, I ate now, I dosed my medication now, and they can see what did that do to my sugars. So you can already start to see like how this can help patients take better care of themselves with all this extra information. It also gives trends, so it'll tell you, hey, your sugars are rising too quickly, they're falling too quickly, you should do something about that. And then what I like is that as a provider, if the patient grants me access, I can log into the website and I can see a lot of information about that patient's blood glucose. So a way that this would typically work before a patient visit is I'd know, hey, I've got patient A coming up, I'm gonna log in, I'm gonna check their sugars about 10 minutes before. I already have so much information from this patient, just from this graph. I'm ready to have a good conversation with them about how we can manage their diabetes better, as opposed to spending 10-15 minutes having them relay to me what all their blood glucose readings are. And then we also have to rely on, how accurate all those readings were, and, did you really write down the actual time you took it, and things like that. So a very exciting new area, technology-wise, specifically for people who manage diabetes. The amount of information we can get from these is amazing. Kind of in that same vein, this is also some technology that's available for diabetes, and these are smart insulin pens. So those two, the red and the gray devices there, are insulin pens, which is just a plastic device that has a vial of insulin inside, and then you can attach a needle, so that's how patients can dose their insulin. They kind of turn the knob at the back to select the dose. Before, that's all they used to do, but now we have pens that are Bluetooth enabled and can talk with an app, and they can help record what dose you gave yourself. But if you are also connected with, say, a continuous glucose monitor like we just talked about, it can record the dose you gave and correlate that with your blood sugar at the time. So it gives the provider a lot more information on, one, how often are you using your medication, how many units are you giving yourself, and then when you did that, what did that do to your blood sugars? Okay, switching gears to a different chronic disease state, there's also some exciting advancements in the respiratory area. These are specifically some inhalers that are marketed for asthma, and they're called DigiHaler. No surprise, they are Bluetooth enabled and they connect with an app. Again, you can share the information from the app with your provider. So just a little basic information on asthma. There's usually two kinds of inhalers that patients use. One, a maintenance inhaler that they use every day to prevent shortness of breath. And then two, a reliever inhaler that they use when needed when you're having, say, an asthma attack or an episode of shortness of breath. Why is this important? It's important because oftentimes patients don't notice the benefit immediately from those daily maintenance inhalers. Instead, they find that short-acting reliever inhaler, that's the one that really works, so they just use that one. But we know that long-term, there are grave consequences from not using that maintenance inhaler every single day. So why is this important? There are apps like this that can help us track, one, how often the patient is using their medication. So I can see as a provider, like, were you using that maintenance medication every day? And is that correlating, to less episodes of shortness of breath? So that's part of what's showing right here. It's showing when medications were used. And then also I can see how often did you need to use that short, fast-acting inhaler because you were having those shortness of breath episodes. So that gives me an idea of when are you getting short of breath? Is there a pattern? Is there something that we can identify, to make your asthma and your breathing control better? Oh, that showed up in the wrong way. Dang it, so good for technology. Okay. The other thing that these inhalers do that are really exciting is that they track how well you are breathing, meaning they have information on the inspiratory force you're using when you use your inhaler. That's important because these inhalers can be kind of tricky. They seem like, hey, it's a medication to help people breathe. We should make it easy to use when you breathe. But you actually have to use the right technique to get that medication where it needs to go, which is down into the lungs. So if you're not breathing with the right technique, like you're breathing in too quickly, these medications don't work as well. So this app tells me, are you breathing with the right technique to make these medications the most effective? So it gives me as the provider some information on, do I need to have a conversation with my patient about inhaler technique? They also provide some pop-up reminders, reminding patients. So if it's connected to your phone, it says, hey, it's time for that maintenance med. Make sure that you take it right now. All right, let's wrap up remote patient interactions with some devices that are aimed at the cardiovascular system. So first we have a scale. It's digital, it's Bluetooth enabled, and it connects to an app. So again, we see the theme here. This can be helpful for disease states like heart failure, so where it's really important to monitor a patient's weight every day. I have worked in clinics before where every time we have a new patient with heart failure, we send them home with one of these Bluetooth enabled scales. So every morning they check their weight, and then I come into clinic, I pull up my patient list, I get to see everybody's weights, I can see if there's any big deviations, anyone that I need to interact with immediately, any trends that we need to be aware of. Here's a blood pressure monitor. This guy looks very happy checking his blood pressure. It's probably because it's Bluetooth enabled and it's going right to his phone. So blood pressure is a big one where it seems like it's really something simple to check, so why do we need this technology? But there are some interesting caveats with hypertension or high blood pressure. One is there's a significant percentage of patients who get anxious in the clinic, and their blood pressure is higher than normal every time they see the physician. So if you come into the physician and your blood pressure is high, what happens? We increase your med, or we give you a new medication. But if your blood pressure is elevated just because you're anxious and it's not your true reading, then that's not the safest thing for you. So these remote blood pressure monitors can be really helpful because patients can check them at home using the ideal technique, sitting, relaxing, and getting a real baseline blood pressure value. So then we can make decisions off of real blood pressure values and not those elevated, anxious clinic readings. In my telehealth clinic, we also send every new hypertension patient home with a Bluetooth-enabled blood pressure monitor. It kind of has the same thing as the continuous glucose monitor. You can pull up a report that shows trends, and it shows when pressures were taken and what those pressures were. And then finally, here's a piece of tech which I'm sure a lot of us might be wearing at this moment, which is a smartwatch. They collect a lot of health information. I know mine, right when I started talking, was like, your pulse is up. So that was helpful for me to know. But there are some that actually check blood pressure. So they have like a little blood pressure monitor right in the watch, and they can check and again, send that information to an app. Some can check oxygen levels, so that can be helpful for certain disease states as well. Okay, back to my very favorite topic, which is adherence tools. Anything that we can do to help our patients buy in and understand and make it convenient to take medications in the way that they'll work the best for them is kind of falls under this adherence tool bucket. The most low-tech adherence device is the good old pill box. So it's just a box with labels for days and times. So that's my example of starting at the bottom. Then they get a little bit more technologically advanced. This example has an alarm and has 28 different slots. So you can put medications in there and the alarm goes off. So something to help you remember. Doesn't do much for, it doesn't connect to anything. So slightly more technologically advanced. Then we have some things like this product called the MedMinder. This one is Bluetooth enabled, connects to whomever the patient would like it to connect to. So it can connect with a caregiver or with a physician. And what it does is it lets those people know if medications have been taken, or at least it lets them know if medications have been withdrawn from the device. So it's a good way for patients to have a little bit more control of their medicines. Say they're forgetting to take their medications and that's making them less healthy. If we're an older individual, that could be a reason to say have to move to another level of care, like an assisted living. If you can use a device like this in your home and help prevent that, keep that independence going, they can be really powerful tools. This is a very advanced device. This is from Philips. It actually comes with packets that are pre-packed with doses. So say your morning meds all come in a package. This whole device comes shipped to you full of the meds, and then when it's time to be done, you ship it back and they give you a new one. And it has an alarm. It asks you some other function about how you're feeling when you take it, and again, it lets caregivers, family, and friends know, anyone that you'd like, know if you've taken your meds. And then this is one of my favorites because they seem very simple, but they're just adherence-enabled pill bottles. After the bottle has been opened, the color on the bottom changes. So it lets the patient, one, know, yep, I've taken my meds, and then also it connects, it's again, Bluetooth enabled, so it connects with caregivers and providers to let them know that the bottles have been opened as well. And then finally, have to talk about apps if I'm going to talk about adherence tools. There are many, many apps on the market that can help patients remember to take their medications. From the most simple to very complex, but the most simple is you just enter in the medications that you take with the schedule that you want to take them on, and they give you reminders of when to take them. The reason I picked these two is that there have been studies done to show how effective these are, and these are two of the ones that have shown up on top. And again, they're relatively inexpensive for patients as well, but they have good data saying that they do improve adherence. Okay, so who benefits? Hopefully from my talk, you have learned that a lot of people can benefit from more technology in healthcare. For patients, the biggest thing, in my opinion, is one, it's access to care, and then having more control over the management of their disease state. So more information along with context can always be helpful to, to lead to those better outcomes because we can do a better job managing our health care. And then for providers, most providers will say when interviewed that they like doing telehealth. It gives them a good work-life balance. When I do telehealth, I can see more patients, so I can be more effective. I feel more impactful. And then we also have studies that show overall there's cost efficiencies and improved outcomes from use of technology. I think I'm right on time. Okay, so thank you very much. I will take any questions.
Any questions? Okay, hang on 1 minute.
Are there patient adherence assists for clients who have dementia and don't remember if they took their medications, and seeing that pill bottle turn color, how long does it stay that color, and what about 5 o'clock that afternoon when they took a pill that morning? What do we do?
Yep, so there's definitely limits, and there are some that are better for different patient populations. For a patient like that, I would do either the big computer-looking one, that Philips one with the smiley face, or the one that looks like a laptop MedMinder, because those will tell you this dose has been taken. So it would always say like Friday's 4 p.m. dose has been taken. So that might be an option. Obviously, it kind of depends on the level of understanding and ability. But some of these, you're right, work better with caregiver assistance in that situation. Yeah. You're welcome. Thank you for the question.
Yes, I was wondering, with those more advanced tools, are they often covered under insurance with the Bluetooth? I know that regular blood pressure cuffs and things like that are, but about the more advanced ones.
For adherence tools or for kind of any of them?
Mainly the adherence ones, but anything really that's Bluetooth, not the smartwatch.
Okay. It's definitely improving, and it obviously depends on the insurance, but the first ones I talked about, the continuous glucose monitors, are covered by a lot of different insurance providers now, and the restrictions on them, like the requirements to meet coverage, have been coming down and down. Before, you had to be on like 4 times a day insulin, and that's no longer required. I will say part of my clinical practice, I was spoiled because we worked with 1 or 2 insurance providers, and so we knew everything that was covered, and we could lobby for that. So we had the scale was covered, the blood pressure cuff was covered. I have seen one plan that has covered certain smartwatches, like part of the smartwatch. I guess what I'd say is that I would hope it continues to improve, but cost is definitely a barrier for some patients. But thank you for that question.
On the continuous blood glucose monitors, a lot of times the requirement is that you have to be on insulin before the insurance company will pay. Is that prevalent throughout the insurance industry, or is it just certain providers that require that?
The most recent that I've seen is that for type 2 diabetes, you do have to be on insulin. I'm looking if I have any other experts. Does anybody know if there's other? Have you seen somewhere they don't have to be on insulin? Okay. I've had a patient where we've had a prior auth, so like extra paperwork required, when they've had really bad outcomes from medications, and they have like labile blood sugars that go down very often, so, but not frequently. But yeah, hopefully in the future.
Can take one more question.
Thank you. Just a comment about your question about people with dementia, potential dementia. So next to you, there's a flyer on a medication adherence study, and that is a technology study. It is a smartphone app. It's an iPhone app with the companion website, and we are currently testing it in people with hypertension who takes at least 1 hypertension medication, 65 and older, but that particular app, the system has been converted to people with mild cognitive impairment, and we're going to be testing that soon as well. So hopefully, we are doing research in the area to be able to not only impact medication adherence in normal aging adults, but also older adults with potentially dementia or dementia picture. That's it. That's it. So. Right. So that current study is not involving mild cognitive impairment patients, but we have a study upcoming. We're hoping to start within about 6 months. That will be targeting MCI population. Okay, thank you. Help us recruit people for our study.
Okay, thank you, Dr. Zerr.
Let's see. Excuse me, because I'm getting over a cold, so. All right. So Dr. Campbell will introduce updates to clinical practice guidelines for some of the most common targets, while share open access resources that are available to both healthcare professionals and the public. Please join me, Dr. Campbell.
All right. Thank you so much, Dean Schnellman. Okay. Looks different on this side. All right. So I am very honored to be speaking with you all today and wanted to thank Dean Schnellman for inviting me, as well as Jeff Javier for hosting this event tonight. It's been really amazing to be here, and I'm looking forward to chatting with you all. So I don't have any fun pictures for my introduction like Dr. Zerr had, but a little bit of background on me. So I am from Pennsylvania originally, and I went to University of North Carolina for pharmacy school. I also did undergrad in North Carolina. And then when I finished pharmacy school, I moved to Pittsburgh and completed 2 years of postgraduate residency training. And my second year was a specialty year in geriatrics. So I love working with older adults. That's my population of choice. I have been here at the U of A. This is going on 8 years, which is kind of hard to imagine now. But I am loving every minute of being here. I love Arizona. It's a great place. And in terms of my clinical practice, I worked at Banner UMC Tucson for the past 7 years in both internal medicine and geriatrics, so on the inpatient side in the hospital. And I would round on the geriatric consult service with our geriatricians, primarily seeing folks who are coming in with falls and hip fractures, as well as our 80 and up patient population coming in with geriatric trauma, so primarily falls and brain bleeds. So I'm really excited to talk about one of my favorite topics today, deprescribing when less is more. So, in medicine, we're very fixated on constantly adding medications, right? So you feel like every time you go to the doctor, there's the potential to maybe add a medication. We're adding. But we don't always think about, can we actually deprescribe medications in addition to adding? Do we need to be on all of these medications forever? So I did want to start off with a bit of a disclaimer here. All the information that I'll be providing today is for informational purposes only, and please do not construe it as medical advice in any way. We will be talking about several medications that could potentially have some long-term side effects in everyone in general, but particularly in folks who are older. And again, not everyone's going to experience these side effects, so I want to drive home the point that deprescribing or stopping medications is always going to be a very individualized process. So always consult with your primary care doctor or whoever prescribes those medications for you if you do have any questions, particularly at the end of today's session regarding any of the medications. I did want to start off by talking a little bit about some of the normal physiologic changes that occur as we age. So the first three we're going to talk about is kind of your difference in your body composition. So as we age, we tend to have higher percentages of fat than when we were younger, and our total body water and muscle mass, unfortunately, goes down. This is a generalization, but overall, this is kind of how our body composition tends to change. And really where this comes into play is there's a lot of medications that may be highly water soluble. So one really good example that we'll talk about today is aspirin. So aspirin is a very water soluble medication. And if you have a reduction in your total body water, your amount of aspirin, your concentration could potentially go up. There's a lot of other reasons why aspirin can lead to more side effects in older adults, but that's one of the reasons, one of the things that we get a little bit concerned about. Another thing to point out is increased fat. So there are medications that distribute into the fat and kind of linger there. And one classic example of a fat-soluble medication is Valium or diazepam. And so that medication can kind of distribute into the fat and tend to stay there for longer. And there are risks associated with this with people having increased buildup of these medications. So there's a lot of different ways that we can see our levels of meds change as we age. All right, so the next one here is serum protein. So as we age, we tend to have less albumin in our bloodstream, and a lot of medications are bound to albumin. And one example is a seizure medication, phenytoin, where if you're taking phenytoin and you have less circulating albumin for the drug to bind to, you're going to have increased concentrations of free drug. So other things to consider here too. Decreased responsiveness of baroreceptors, so meaning baroreceptors being those that response you have when you stand up really quickly that helps to kind of re-equilibrate your body. You have decreased liver mass and blood flow, so drugs are metabolized a little bit slower, and kidney function, it tends to go down as a product of age as well. And so we tend to see slower elimination of medications, which can actually lead to kind of dose stacking or medications kind of having lingering effects as we redose. So Dr. Zerr actually alluded to polypharmacy in her previous talk. And polypharmacy is a very general term, but in general, it is the concurrent use of 5 or more medications at one time. And there's a lot, you'll hear 4, 5, 6 different numbers, but generally speaking, 5 is kind of the agreed upon number. And polypharmacy involves not just your prescription medications, but your over-the-counter meds, your herbals, vitamins, supplements, everything that you are taking. And the reality here is that polypharmacy is probably unrecognized because 53% of older adults report taking 5 or more medications. And when you count over-the-counter products and supplements, 67% constitute polypharmacy. But there's also about 25% of adults who don't report any supplement or herbal use. So we probably are seeing, these numbers are probably underestimating the true prevalence of polypharmacy in our population. And what are the consequences of polypharmacy? People are on more drugs, so what? Well, that's an increased risk of errors, increased risk of drug interactions. It's more difficult for people to remember to take all of their medications. I mean, Dr. Zerr showed us some great things that we can use for that, but if you're on 10, 20 medications, it's very difficult to remember. And this can lead to adverse drug effects and ultimately lead to falls, hip fractures, hospitalizations, kind of have some downstream effects. So we really try to think of the mindset of less is more. And I really like this comic because it touches on something that's pretty well known as the prescribing cascade, or essentially, prescribing a medication to treat the side effect of another medication. So, well, white pill lowers my blood pressure but makes my legs swell. The yellow pill lowers swelling, causes me to pee. Blue pill causes me to pee, or stops me from peeing but makes my memory, but makes me confused. Tan pill improves my memory but makes my nose run. Pink pill stops my nose from running but makes me sleepy. Orange pill wakes me up but increases my blood pressure. And then so the white pill lowers my blood pressure. So it's just a giant circle. And there's a lot of opportunities to deprescribe, and we don't necessarily always need to be on every medication. So it's always good to revisit what we're on. And there's 3 kinds of polypharmacy. There's pseudo-polypharmacy, which is basically where the patient's record shows that they're taking 5 or more meds, but they might not actually be. They might have old medications that are in their list that just need to be reconciled. There's appropriate polypharmacy. So a great example here is somebody who has heart failure with reduced ejection fraction. These people are going to be on very appropriately at least 5 or 6 medications, because there's a lot of medications that have mortality benefit in heart failure. So that would be an appropriate form of polypharmacy. But what we're going to focus on here is inappropriate polypharmacy. Woo! So this is where the patient is taking more drugs than are needed or medications that are unsafe. And the potential issues with this, there might be medications that are inappropriate for an older adult. They might be on medications that interact with other meds. They might have medications that aren't effective for their diagnosis. And there may even be situations where they have duplicative therapy. And where this comes into play is when people are seeing primary care providers and may also have a cardiologist and a nephrologist, and perhaps they're being prescribed the same class of medication, and then the pharmacist in the community is the one who's identifying this and kind of resolving that issue. But the big solution is to have a discussion, consider deprescribing or replacing with better therapeutic alternatives. And whenever we're stopping a medication, the first question we always want to ask is a taper required? Because some medications do have some withdrawal effects. So the Beers List is a great resource that is published by the American Geriatric Society. It was originally published in the Annals of Internal Medicine back in 1991, and it has since been taken over by AGS, and they update it every 3 to 4 years. And lucky us, it was recently updated in May, so we have some new information to work with. And this list of potentially inappropriate medications in people who are 65 and up is it's not necessarily a stoplight, it's kind of a yellow light. So these are medications that if you're on, you kind of want to assess, is the risk-benefit profile going to be worth continuing this medication? Because in many cases, it will be. The caveat with the Beers List is that it only applies to people, general population, not people who are hospice or end-of-life care. And you might be wondering why it's the Beers List. Beer is okay, that's fine, but it's actually named after physician Mark Beers, who originally developed this. So why do we deprescribe? I alluded to the fact that some meds might be unsafe, not effective. There's oftentimes situations where patients are just interested in stopping medications. There may be instances where there's not a compelling indication for a med, and we'll talk about that in future slides. And then finally, there are also medications that may take a few years to actually take effect, to get the full benefit. And if somebody's life expectancy does not exceed that time, then it may not be worth it to initiate that medication. And one great example here is our osteoporosis medications usually take about 2 years to really take effect. So if somebody, you wouldn't be surprised if they passed away within a year, probably wouldn't be worth starting. So there's a lot of medications that have deprescribing guidance. There's a lot of resources out there. We're going to focus on the ones that are bolded in blue. The Deprescribing.org is a really excellent resource, and the Canadian Deprescribing Network has put out some amazing references, put out a lot of evidence-based practice guidelines for deprescribing. So a lot of this will be based on that, but there's also some recommendations that we'll talk about from the Beers criteria and the U.S. Preventative Services Task Force. So starting with some prescription meds, we've got anxiety and sleep meds and diabetes med. So anxiety and sleep meds, so as we age, we tend to be more sensitive to these meds. And some of the medications that I'm referring to here are your benzodiazepines, or a couple examples would be alprazolam or Xanax, lorazepam or Ativan, diazepam or Valium, and then our Z drugs. So our Z drugs are commonly used for sleep. So these are similar, they work in a similar way to the benzos. So there's zolpidem or Ambien, you may have heard of, or izopiclone or Lunesta. And as a result of being more sensitive to these side effects, as we age, we can have increased risk of confusion or change in thinking, an increased risk of falls, car accidents, and hospitalizations. One of the really important considerations when you are thinking about discontinuing a benzodiazepine is that there is a rare but serious side effect, particularly in people who've been on them for a long time, that they may have withdrawal seizures. So, there are common side effects of insomnia, anxiety, some GI symptoms and sweating, but, this is one of those drugs that we're going to want to do a long taper no matter what, because, or in almost every situation, to be able to get the patient off of it. And you can see on this example taper, this one is actually over 18 weeks, and these are some evidence-based tapers that were provided by a study group called the Empower Group out of the Canadian Deprescribing Network. So moving on to diabetes management. So diabetes management changes as we age, which is, a lot of people are not necessarily aware of this, but because we are more susceptible to low blood sugars with aging, there's medications that can actually cause our blood sugars to go too low. So insulin, our sulfonylurea family of glipizide, glyburide, and so it's one of the things that tends to come up as we get older is, do we want to have the same blood sugar goal as we had when we were younger? And so in an otherwise healthy individual who has diabetes, living with diabetes, adult, their A1C goal, which is kind of an average of your blood sugar over a 3-month period, would be less than 7%. However, as we age in an otherwise healthy older adult, the blood sugar goal would be 7 to 7.5, and then that blood sugar goal can actually go up depending on your comorbidities or your other chronic conditions, as well as your functional status. So the American Diabetes Association and the American Geriatric Society endorse these, and these were actually updated. They get updated every year. So those are kind of your latest goals. In terms of over-the-counter meds, we're going to talk a little bit about proton pump inhibitors. There are some prescription ones, some are OTC. I put them in this category. Non-steroidal anti-inflammatory drugs, and we'll talk about honestly, the most controversial drug of all time, aspirin. So we've got proton pump inhibitors. You probably have seen these before, so it doesn't look like the whole thing is showing up, but omeprazole or Prilosec is one of your examples. Commonly used for gastric reflux or ulcers, and also we use them in the intensive care unit for stress ulcer prevention. And because they lower, or they increase the pH of your stomach, and they kind of interfere with that normal physiologic pH, there are some consequences with using these long term. And this is particularly related to the absorption of important vitamins and minerals. So calcium, magnesium, vitamin B12. So we do tend to see a risk of fractures from decreased bone density from a long period of time. There's also risks of infection because there's theoretically you could potentially interfere with one's immune system when using these long term as well. So there's been some studies associating long-term proton pump inhibitor use with pneumonia or Clostridioides difficile or infectious diarrhea. And then again, other vitamins and minerals. And there's some emerging information about chronic kidney disease as well. So who do we consider stopping a proton pump inhibitor in? There's a lot of people who are on these. They're some of the most common medications that you'll see. And there's some people who may just need to be on these long term. So I do want to throw that out there. These are not going to apply to anybody just everybody who's taking a PPI. But if you did have, say, a stomach ulcer that has been treated for 2 to 12 weeks, you have an maybe you had some symptoms of reflux, and your primary care doctor said to start this omeprazole and didn't actually do a scope on you. you could actually, and you haven't had symptoms in 3 days, for 3 days in a row, then you could consider stopping. Like I said, in the ICU, when patients are there, there's a high risk of having stomach ulcers, and so we do stress ulcer prophylaxis with these medications. And then there's also the H. pylori infection that has been uncomplicated and treated for 2 weeks. So these are kind of the categories that have been mentioned in the Deprescribing guidelines. There's also a couple categories of people who may be able to take a lower dose. So maybe lower the exposure of the proton pump inhibitor, or even use it on demand. And these are people who, are listed there. Maybe they don't know why they're taking it. Maybe they had reflux that was treated for 4 to 8 weeks and they're not having symptoms anymore. Do they really need to be on it still? And so you can either reduce the dose or you can do on-demand dosing. So on-demand dosing is basically just starting the drug so stopping it and then starting it back up when the symptoms go away, and then stopping it starting it up when symptoms come back, stopping it when symptoms go away, just to minimize your exposure. Other things, just your non-pharmacologic considerations, avoiding those dietary triggers. If you do stop something, a PPI, having small meals, avoiding spicy foods, citrus foods, tomatoes, coffee, things that are really irritating on the GI tract, and chocolate. All right, so we're gonna move into our other class here of drugs, the NSAIDs. So these are your ibuprofen, Advil, Motrin, Naproxen, Aleve drugs, and thinking about aspirin in doses greater than 325 as well. Commonly used for pain, arthritis, and headache all over the pharmacies. So, as we age, we tend to have greater susceptibility to the side effects of these meds. So one of the really big concerning side effects is gastrointestinal bleeding. People can also have an increased risk of elevating their blood pressure and increased risk of kidney injury. So there are some safer alternatives to NSAIDs. So Tylenol is a great option, as well as some of these topical agents that I have on this slide. All right, so what about aspirin? Everyone should have aspirin, right? It's good for what ails you. My grandma always took a daily aspirin, and she told me that it was, good for everybody. It's just everyone should take an aspirin. And I was always like, I don't know, I'm not sure, I'm skeptical, but not so fast. So the biggest concern with aspirin as we age is bleeding. And it is very commonly used, and it's over the counter, readily available. Some people use it for pain or headache. That is a very old school practice. And this is particularly in higher doses too. So people would use 650 milligrams when, our kind of cardiovascular dose is 81 milligrams daily. And so the risks of bleeding with these doses are really going to outweigh the benefit. There are instances in some patients who may need to be on long-term aspirin. So if you've had a stroke or a heart attack or maybe stents placed in your aspirin, these folks are going to qualify for more long-term aspirin for secondary prevention of having any of these kind of events. But then there's this group of people where you're using it for your heart, just, for heart health. So that's primary prevention of cardiovascular events, meaning they've never had any kind of cardiac event in the past. They've never had a stroke, heart attack, a stent placed. Maybe they don't have peripheral arterial disease. These people, there's a lot of questions, or there were at least, and there still remain questions out there. But this ASPRI trial was published in 2018 in New England Journal, and they looked at over 19,000 older adults, and the median time that they followed them was for 4.7 years, and basically found that low dose, 81 milligrams daily aspirin, had no benefit with regards to the composite outcome of death, dementia, or persistent physical disability. But there were higher rates of bleeding versus placebo. So this study kind of provided some insight for us as to what maybe we should be recommending for our patients. And there's still some controversy surrounding this, so I don't want to say this is a black and white thing. But in 2019, the American College of Cardiology, American Heart Association put out a recommendation to not give aspirin routinely for primary prevention. So we're talking about that yellow population on the last slide. And then in 2022, the U.S. Preventative Services Task Force put out a very low-level grade D recommendation recommending against initiating aspirin in older adults. And then this past year, the American Geriatric Society followed suit and said to avoid initiating aspirin for primary prevention of cardiovascular diseases, and they also said to consider deprescribing it in people who were already taking it for primary prevention. So, you know, I think we're getting more comfortable, or we're starting to see that maybe aspirin didn't quite have the benefits that we once thought it did. Again, this is always going to be an individual decision made on an individual basis based on the patient's characteristics, but I think we are kind of moving away from using aspirin because it's good for what ails you. All right, so I did want to leave you all with some resources for deprescribing. So this QR code here will take you to the Canadian Medication Appropriateness and Deprescribing Network. And there's a lot of excellent resources on there that have information about all of the classes that we talked about, but other medication classes as well. And they even have patient-specific resources. So if you're a patient or if you're practicing in pharmacy or in healthcare in general, there's provider and patient resources. And there's the patient resources have really great packets that you can kind of fill out, and you can actually use them to have as a conversation starter with your prescriber. So I think they have some really excellent resources there. And deprescribing.org is another really great resource that has those guidelines and whiteboard videos and things like that that really have some good education to them. So that is all I have for you. Like to always end with letting you know that you're always going to be your number one advocate. So ask questions and, you know, stick up for yourself and for your loved ones. So thank you so much for your time. I appreciate it, and it's good chatting with you all. It's dinner time, I think, so.
We can take a few questions. No questions? Okay.
I'm sorry, I'm forgetting one of the words in my questions, but do physicians make a judgment when they look at the list of medications and it exceeds the 5+, including supplements?
I think if there are more than 5, that's a great question. Yeah, I think if there's more than 5, it kind of puts off a little bit of a, I don't want to say red flag, but it kind of makes you want to really do a good medication review for that patient just to ensure that there's no drug interactions. Kind of gives you that little extra to make sure that everything's reconciled and there's not, you know, we don't have pseudo polypharmacy where maybe they're only taking like one of those drugs. Any other questions? We're ready for cookies. I am. Well, thank you all for coming today. It was really nice chatting with you all, and hope you have a great night.
All right, thank you, Dr. Campbell. Once again, thank you for all attending our second talk in the series. We look forward to seeing you at our final talk next Tuesday, which will focus on drug discovery process, including challenges of delivering breakthrough medicines to bedside. So thank you for coming, and hope to see you again.